The United States represents the world's largest healthcare market, nearly $4 trillion annually. What happens in U.S. healthcare influences global pharmaceutical development, medical device innovation, digital health technologies, and healthcare's investment worldwide. But here's the challenge. Despite being the most expensive healthcare system in the world, the U.S. doesn't achieve the best outcomes. I've spent about 20 years working at every level of healthcare, from technology, data analytics. I led STARs and quality programs, risk adjustment programs for some of the largest health plans in the U.S. Consistently achieved 4 to 1 ROI on risk adjustment and quality programs. The American healthcare system wasn't designed perfectly. It evolved through a series of policy changes that each made sense individually at that point in time, but created enormous complexity collectively. Here's the bottom line. The current trajectory is unsustainable. Healthcare inflation continues, outpacing GDP growth. If nothing changes, we are looking at healthcare consuming 25% or more of the economy. That means higher premiums, reducing take-home pay, rate of federal deficits competing with other priorities, reduced ability to invest in education, infrastructure, and innovation. What are the paths forward? What I'm about to explain isn't just a theory. These are managed care frameworks that have driven real results in the real world. And they matter whether you are in Boston or Bangalore. This isn't just a podcast for stars, risk adjustment specialists, or Medicare Advantage experts. This is a resource for anyone trying to understand how the world's largest healthcare market works, why it's struggling. Welcome to the Healthcare STARcast. I'm Subbu Ramalingam, and whether you're joining us from New York or New Delhi, San Francisco or Singapore, Tokyo or Toronto, welcome. Today, we are starting a two-part series that explores the fundamentals of the U.S. healthcare system. Now, I know many of you listening work in healthcare systems around the world, specifically in the U.S. You might be wondering, why should I care about the American healthcare market? Here's why. The United States represents the world's largest healthcare market, nearly $4 trillion annually. What happens in U.S. healthcare influences global pharmaceutical development, medical device innovation, digital health technologies, and healthcare's investment worldwide. American health systems are laboratories for new payment models, care delivery innovations. We saw it in RNA type vaccines, several pharmaceutical development, medical device such as blood pressure monitoring, blood sugar monitoring, you name it, and technology platforms that eventually reach global markets. But here's the challenge. Despite being the most expensive healthcare system in the world, the U.S. doesn't achieve the best outcomes. Understanding why and what's being done about it matters whether you are in the trenches of risk adjustment, you're developing an AI application, whether you're in quality, whether you are in population health management, other health tech policy, or anywhere in the global healthcare ecosystem. And right now, we are witnessing this play out in real time. As I'm recording this, the U.S. government is still in the midst of its long shutdown in history. At the center of this, healthcare policy and funding decisions that affect millions of Americans. This isn't just a podcast for stars, risk adjustment specialists, or Medicare Advantage experts. This is a resource for anyone trying to understand how the world's largest healthcare market works, why it's struggling, what can we do about it, what are some frameworks to really help the efficiencies and overall outcomes for the entire population. Today, we'll explore the landscape, and how managed care works. Let's get started. Let me start with the headline. The United States spends approximately $4 trillion annually on healthcare. That's more than the total value of all U.S. exports combined. Healthcare consumes about 20% of the entire U.S. economy. $1 in $5 goes to healthcare. For context, in the 1950s, that number was less than 5%. So in roughly 70 years, healthcare's share of the economy has quadrupled. At the federal level, the government spends approximately $2 trillion on healthcare programs, making it one of the largest categories of federal spending, representing about 27% of the entire federal budget. To put that in perspective, that's more than double what we spend on national defense. This money flows from three sources. About $1 trillion from consumers directly, $1 trillion from employers, and about $2 trillion from federal and state government programs through programs like Medicare and Medicaid. To put the scale in perspective, Medicare covers about 67 million Americans, roughly 1 in 5 adults. In fiscal year 2024, Medicare spending alone was about $912 billion. Medicaid and CHIP together covers 71 to 78 million people, about 23% of the population. Federal Medicaid and CHIP spending was about $626 billion in fiscal year 2024. Employer-sponsored insurance covers another 150 to 160 million people. And the numbers are growing, not shrinking. Within Medicare, there's been a dramatic shift. As of 2025, 34 million people, representing 54% of the eligible Medicare beneficiaries, are now enrolled in Medicare Advantage plans rather than traditional Medicare. That means more than half of Medicare beneficiaries have chosen private managed care over the traditional government-run program. That's a topic in itself. Now, here's where it gets interesting and frankly troubling. In 2021, the U.S. spent about $12,197 per person on healthcare, comparable to other wealthy and developed nations, Germany, France, Canada, the UK, Australia, Japan, etc., spent an average about $6,514 per person. We spend nearly twice as much per capita as other developed nations do on healthcare. And what do we get for that extra spending? Not better outcomes, according to the data. In fact, the U.S. now has lower life expectancy than most peer nations. Higher maternal mortality rates. We see doctors less frequently. We have more difficulty accessing care. Take rural healthcare settings as an example. The extra spending doesn't go to more services. Americans actually have shorter hospital stays and fewer doctor visits than people in comparable countries. The difference, as you can imagine, is price. Everything simply costs more in America. Where does the money go? The largest gap is in hospital and physician payments. That's about 80% of the difference. We also spend nearly 4 times as much on administrative costs as comparable countries. That's the cost of complexity, tracking billing, managing a fragmented system with multiple payers, different rules, and endless paperwork. For our international listeners, imagine this. In most developed countries, there's one payer or a handful of standardized payers. In the US, there are hundreds of insurance companies, each with different networks, different formularies, different prior authorization requirements. So a hospital might contract with 20 or 30 different payers, each paying different rates for the same procedure. What do other countries do differently? Price regulation. Governments in other developed nations negotiate drug prices, set fee schedules, and cap what can be charged. The US largely doesn't. For decades, the government was actually prohibited from negotiating Medicare drug prices. Simpler systems? Whether it's single payer like Canada and the UK or multi-payer like Germany and France, other countries have relatively more standardized processes and fewer administrative layers. Different payment models. Most have moved away from paying for every individual service and instead use global budgets, capitation, or other value-based approaches. Well, there is a trade-off here. Some countries have longer wait times for elective procedures. We hear a lot about in UK and Canada as an example, but their overall population health metrics are generally better, and they spend half as much as achieving them. What are the current policy challenges around healthcare affordability? Now, let me bring this also in the current context again. Right now, there's significant uncertainty around healthcare affordability in the United States, particularly for the individual insurance market, better known as ACA or Obamacare. The Affordable Care Act created insurance marketplaces where about 24 million Americans purchased health insurance. Of those 24 million, about 22 million, that's 92%, received enhanced premium tax credits. These are federal subsidies that make insurance affordable. In theory, we have to see whether that's actually really in practice. Another discussion for sure. These enhanced subsidies were introduced in 2021 and extended through December 31st, 2025. They're currently set to expire at the end of this year. What happens if they expire? The numbers are stark. Premiums are projected to more than double on average, a 114% increase. An average annual premium would jump, sometimes double. But the impact varies dramatically by income and age. A family of four earning about $70,000 could see their annual premium cost increase by over $3,000. A 60-year-old couple earning just over $85,000 would lose their subsidy entirely and face annual premium exceeding $22,000. That's nearly a quarter of their annual income just for health insurance. Open enrollment for 2026 coverage already started as of last week, as of November 1st. Millions of Americans are currently seeing these potential premium increases as they make enrollment decisions. Well, there's a reason why I'm illustrating this. This is not a political conversation. This product context in this situation illustrates several fundamental challenges in the American healthcare system. First, the ongoing tension between affordability and sustainability. Healthcare subsidies help millions afford coverage, but they also represent significant federal expenditure, about $125 billion annually in just ACA or Affordable Care Act marketplace subsidies. Second, the fragility of coverage. Unlike employer-sponsored insurance or Medicare, individual market coverage is subject to annual policy changes that can be dramatically in effect on affordability. Third, the complexity of healthcare financing. Many Americans don't fully understand their coverage until they need to use it or face a premium change. I am part of the healthcare business and the whole environment. Even I couldn't fully understand many times on the premium changes on the coverage me and my family are getting. For our international listeners, this illustrates why managed care has become so important in the healthcare system in the US. It's one of the mechanisms that provides most stability, predictability, and even as policy debates continue. How we got here. The historical context here. The American healthcare system wasn't designed, it wasn't designed perfectly. It evolved through a series of policy changes that each made sense individually at that point of time, but created enormous complexity collectively. 1954 brought a pivotal tax change. Employer-sponsored health insurance became a pre-tax benefit. This wasn't a healthcare strategy. It was a tax policy decision, but it fundamentally shaped American healthcare by making employers' coverage the dominant model for working Americans. In 1965, introduced Medicare and Medicaid, bringing the federal government into healthcare financing in a massive way. This ensured coverage for seniors and created a safety net for low-income Americans. Federal healthcare spending exploded virtually overnight. 2010 brought the Affordable Care Act, expanding Medicaid and creating insurance marketplaces, succeeded in reducing the uninsured rate. Medicaid enrollment grew by tens of millions because of that, but also added complexity and contributed to spending growth. Thereby, each layer of policy created new players, new rules, and new complexity, and complexity drives cost. Okay, let's look at the stakeholder ecosystem here. Today's healthcare system involves multiple players with often conflicting incentives sometimes. Number one, payers. Insurance companies and government programs paying for care, trying to control costs while maintaining access. Number two are providers. These are hospitals, physicians, and health systems delivering care, trying to stay financially viable while maintaining quality. Number three, pharmaceutical companies, developing new drugs and trying to recoup massive R&D investments for those drugs. Pharmacy benefit managers. These are intermediaries negotiating drug prices and managing formularies, creating perverse incentives, whether higher list prices, generating larger rebates. Last but not the least, patients like us, our members, navigating this complexity often without transparency into actual costs. So everyone pulling in different directions, which brings us to managed care. What is the managed care solution supposed to do? Before going into that, I want to give a context about my own journey through the system. I've spent about 20 years working at every level of healthcare. So from technology, data analytics, I led STARs and quality programs, risk adjustment programs for some of the largest health plans in the US. I was born and educated in India, started my career in technology with global companies such as Cognizant and JP Morgan, then moved into healthcare when ACA was passed. So I've always looked at our healthcare system with an international perspective, and which has been interesting and valuable. I've seen health in systems around the world, and gives me a different lens on the U.S. health system. At Independence Blue Cross in Philadelphia, I led the vision and strategy to improve star ratings to 4.5 stars and built infrastructure to sustain them to a higher star rating year over year. At Care First Blue Cross in Baltimore and D.C., I built an organization which started just with one person and scaled it from the ground up to 60 plus, not only people, but incredible ecosystems of technology, services, and healthcare services that drives over $1 billion in revenue, covering about 3.5 million lives. I've taken Medicaid quality performance from rank 8 to the bottom to number 2 in select healthcare quality measures. Consistently achieved 4-to-1 ROI on risk adjustment and quality programs. And I've done this across Medicare, Medicaid, commercial plans, and I've also done mistakes and had equal share of successes as well. Why am I telling you this? Because what I'm about to explain isn't just a theory. These are managed care frameworks that have driven real results in the real world. And they matter whether you are in Boston or Bangalore. So let's look at why managed care exists. Traditional healthcare operates on fee-for-service, which is every service generates a bill. Doctor's visit, you get a bill. Get a test, get a bill. Surgery, get a bill, you pay. Follow-up, another bill. So this incentive problem is straightforward, right? More services mean more revenue. This doesn't naturally align with keeping people healthy or delivering value-based care. There's no payment for the care coordinator, helping a patient navigating from hospital to home. No reimbursement for the preventative phone call that keeps someone out of the emergency room, for example. And the administrative burden is massive. Every service must be coded, tracked, billed, and adjudicated. This is why U.S. administrative costs are nearly 4 times higher than comparable countries over several years of time. Managed care flips the model. Instead of paying for every service, in managed care, a health plan receives a fixed amount per member per month, called capitation. In exchange, the plan takes responsibility for all that members' healthcare needs. This changes the incentives. Now the plan benefits from keeping people healthy and using resources effectively and efficiently. Preventing a hospital admission becomes financially beneficial rather than financially harmful. Managed care operates through several mechanisms. Network management. Plans build provider networks with negotiated rates and quality standards. You've heard of HMOs, PPOs, EPOs. These are different network structures with varying flexibility. Utilization management. Ensuring care is appropriate through tools like prior authorizations, case management. The goal is getting the right care at the right time in the right setting. It's a topic in itself, and we're going to do a whole challenges and what we can do in prior authorization, how we can modernize it in a separate episode. But that will be the context of utilization management. Care coordination, especially for complex patients with multiple conditions. Coordinators help navigate the system and ensure providers communicate with the health plan, with the patient, with the members. Do the patient have the transportation? Do the patient, patient has the appointment with the doctor? All the different things that goes into care coordination. Quality measurement. We talked about it in our different episodes. Tackling clinical outcome measures, star measures, patient satisfaction, and other healthcare metrics to drive continuous improvement in the way we deliver care to our members. Value-based arrangements. These are contracts where providers share in savings for better outcomes and efficiency in care delivery. It could be in terms of shared saving in terms of cost, could be certain carrots and sticks specifically for healthcare quality or patient experience, you name it. That all comes under value-based arrangements. Here's what surprises many international observers, in managed care. The U.S. government has embraced managed care for its public programs for a long time. Medicare Advantage is Medicare delivered through private health plans using managed care principles. So in just 15, 20 years, it's grown from covering about 20% of Medicare beneficiaries to over 50%. More than half are in Medicare Advantage. So the Congressional Budget Office projects it'll reach about 64+% by 2034. It may be more. Medicaid managed care is even more prevalent. Most states now contract with managed care organizations to deliver benefits. Over half of Medicaid spending now goes to capitation payments rather than fee-for-service. So why the shift? The same reason private employers moved to managed care decades ago, to control costs while improving quality through better coordination. Both governments and private payers recognize that fee-for-service incentives were driving unsustainable cost growth. I've been in those boardrooms. I've been in those operations. Everybody is trying to get to value-based care. So for our international listeners, familiar with different healthcare models, think of this as America's way of introducing elements of coordinated care and financial sustainability and accountability into these historical fragmented systems. We're trying to do what we can within the fragmented system that we currently have, at the same time trying to change it for the future. So it's not single payer, but it's moving away from pure fee-for-service. Here's the bottom line. The current trajectory is unsustainable. Healthcare inflation continues, outpacing GDP growth. If nothing changes, we are looking at healthcare consuming 25% or more of the economy. That means higher premiums, reducing take-home pay, greater federal deficits competing with other priorities, reduced ability to invest in education, infrastructure, and innovation. Think about all the things that we can do with those dollars. The challenge is getting healthcare inflation to simply match overall economic growth. That alone would be a major achievement. Okay, what are the path forwards include? Number one, price transparency and regulation, making costs visible and introducing more aggressive negotiation, particularly for drugs and hospital services. The government has started that, whether it's in the previous administration or the current administration. There is momentum in terms of building costs more visible, including private players like Amazon and others coming into the market. Social determinants, addressing obesity, food, substance abuse, other behavioral and social factors that drive enormous downstream healthcare costs. I really think that we don't talk enough, even we can talk enough of social determinants of health. That is where our solution relies to reduce costs, but at the same time, it's complex. But there are lots of players beyond just the traditional healthcare community that we need to tap into to improve social determinants of health. Payment reform, accelerating the shifts from fee-for-service to value-based models. Imagine the shift of thinking in terms of contracting that we need to do to bring all these players together from fee-for-service to value-based models. Administrative simplification, reducing that massive administration cost. Take prior authorization, for example. People still live in faxes in healthcare. There's a lot of momentum using AI and using automation, but more to come, right? There are opportunities, but we have to do it correctly and appropriately with the right policies and guardrails in place so that these administrative stuff can be simplified for all of us. None of these are easy. All involve trade-offs. But the global healthcare community is watching because innovation in the US market, whether successful or not, influences healthcare worldwide. Let me wrap this up. The US healthcare system is the world's largest and most expensive, consuming about $4 trillion annually, nearly 20% of the economy. We spend almost twice as much per person as other developed nations, but don't achieve better outcomes. Right now, about 22 million Americans face potential premium increases, and enhanced ACA subsidies are set to expire. This illustrates the ongoing challenges of balancing affordability, quality, and sustainability in American healthcare. The system covers about 300 million Americans through a complex web of employer insurance, Medicare, Medicaid, and marketplace plans. We got here through decades of layered policy decisions, creating a system with multiple stakeholders and misaligned incentives. Managed care and value-based care is emerging as a solution, flipping from fee-for-service to capitated coordination care models. Both private and public players have increasingly embraced this approach, with over half of Medicare beneficiaries in managed care plans right now, with Medicare Advantage. Well, the question is, can this approach bend the cost curve while improving outcomes? So we will be talking about this more. In our next episode, we'll get a little bit more tactical. We'll focus specifically on some of these cost curve bending actions, best practices that we can use not only within the US market, from global markets. And we'll go through some practical frameworks and how that will also influence star ratings, also influence risk adjustment, also influences how you can get a digital and AI infrastructure built to make process and efficiencies much better. And how can we get human-to-human interaction in healthcare also be a key part of it as well. Whether you're in Boston, Bangalore, this matters, because what happens in the world's largest healthcare market ripples across the globe. That's it for today. I'll put some detailed stats and enrollment numbers, all the numbers that I put out there as a reference in the show notes. If you found this valuable, please subscribe and share Healthcare STARcast with your colleagues around the world, whether they are in healthcare or not. This matters in any industry you work in. And tune in next time, and we deep dive in several frameworks and practical and tactical and proven methodologies to really improve managed care and value-based care.